Any feedback for the last session or any questions or thoughts after the session? I hope you remember what we discussed last time. The discussion was on the facilitation skills. So how as a trainer, you need to be really equipped with the, kitty of pedagogies, because you will have to integrate various modalities to make your program effective and facilitate a successful program. I don't know if Dr. Akshita got a chance to have a look at the video. Did you get a chance to see the recording? You saw it? Okay, you saw it. So any feedback from your end or any question from your side? Or anybody, like in case if you have any thought. Dr. Arjun, anything that you wish to ask or say about the last program, last session?
No, ma'am, nothing specific.
Okay, fine. Okay, so all of you, please have your copy and pen ready. And we'll start this session with a small activity, and it's process mapping. So a process mapping of your visit to your hospital OPD, not as a hospital employee, but as a patient. So in this process mapping, keep an eye on the expectations you would have from the hospital as a patient, and note down if those expectations were met or not met. So to start with, imagine yourself entering the hospital gate for an appointment with your doctor. See yourself parking the car. You're not a hospital employee and the parking person does not know you. See what expectations you had from the parking fellow and what those expectations met. So maybe you can write the keyword, the expectation was met or not, or what was the expectation from the parking person. After you have parked your car, see yourself at the reception of the hospital, where you are there to confirm your appointment and to check for the availability of your doctor. Your appointment is confirmed and you have been asked to wait, as there are a couple of other patients before you. Again, check the expectations you had from the receptionist and note down if they were met or not met. Look at the waiting area. Look for a place to sit. Are you happy and comfortable waiting? Note down what are, as a patient, you expect and were those expectations met in terms of cleanliness, comfort, seats available, noise control, presentation of the area. Also, are you okay about the waiting time? Note down. Your turn comes for consultation. You visit your doctor. And if you were not working in the same hospital, obviously you will not know the doctor personally. So look at the quality of your interaction with your doctor and see what those expectations met. Note down. You have been asked to get some blood work done. I hope I'm not going very fast. Okay. So see yourself at the lab, waiting for the blood work, and try to see what your expectations would be from the lab person or the complete setup, and were those expectations met or not. After the lab work, You go to the hospital pharmacy to buy the medicines that your doctor has prescribed. Again, try to focus on the expectations you would have from a good pharmacy and note down whether those expectations were met or not met. You go back to the parking lot, get into your car to return home. Are you satisfied with your visit? Please share your experience or whatever you have written as an answer. Maybe one or two of you can share your thoughts. Were your expectations met? Mostly met? Not met? Who would like to share? Navneeta?
Yes, ma'am. Sir, ma'am, my expectations it will start from the parking area. When I'll enter in the parking area, I'll expect the person, whoever will be available there, to show me the direction where to park my car and all. So, for our hospital where I am working, the people, whoever available in the parking area, they are very good. So I think here my expectation will meet, ma'am. Then next, when I'll go to the reception area, so my expectation will be like to get proper information about my appointment, my time, then for how many hours or minutes I need to wait. So there also, I think in our hospital, or my expectation, it will meet. So next, regarding the consultation, my expectation will be to get the proper information, proper diagnosis about my disease. And when I'll go to the lab, my expectation will be like to get again proper information and to get a warm welcome, because again it is it may be an invasive procedure, so that privacy I'll expect. And then again to the pharmacy, when I'll go to the pharmacy, my expectation will be to get proper information regarding the medicine, whichever will be prescribed for me. So this all will be
but
my
were all your
expectation,
expectations met fully, Navneeta?
Not all, ma'am.
Not all.
But
Thank
somehow.
You. Thank you. Thank you. Anybody else who has different thoughts on the same process?
Like one goes to the parking, so one expects that there is things are in a systematic manner. The person guides you well in which direction to go and help about the parking. So, well, my expectations were met. Then at the reception, one expects the person at the reception to be polite, prompt, and responsive. Like ask how we can help you, and have complete information whether doctor is available or not. Have it on his record. Yes, there is an appointment. Would you please wait for a while? He's occupied with, there is a cesarean happening, so it might take a little time for her to come. So could you please wait? So this is fine. Then you go to the seating area. One expects it to be cool, airy, clean, comfortable, comfortable seating, availability of water, maybe some newspaper or magazine so that you can spend your time. But here my expectations were not met because it was very crowded. There was inadequate seating. There were no directions to the water cooler. So, well, then when the doctor arrived, the doctor was responsive. She listened very carefully to all my complaints, and she did a proper examination. Then she answered all my questions. Then she asked for some blood tests.
Mhm.
And when I went to the lab,
Mhm.
I had to wait for a long time because there was a big crowd,
Mhm.
and the person who was taking the sample had to prick twice to take the sample, which was not very nice.
Mhm.
But it was clean, the seating was proper, and me being a doctor, I also noticed whether they're doing a proper biomedical waste, this thing. So
Mhm.
that was happening.
Mhm.
But yes, I had to wait for a long time and they had to prick twice. So that was uncomfortable.
Mhm.
Then when went to the pharmacy, again there was waiting, but they gave the proper medicine, exactly what one had asked for. It was reasonably priced.
Mhm.
They were giving a 10% discount on the medical at the on the MRP,
Mhm.
and they explained the medicines well.
Mhm.
And then I went back to parking. I was able to get to my car easily and take it out easily. I didn't get stuck anywhere and all.
Mhm.
So it was a mixed experience.
So far.
Wonderful. Wonderful. So, friends, I took you to a very small but very important area of the healthcare delivery system, like OPD. So, similarly, patients visit our various areas with lot of expectations. So, patients' expectations, understanding patients' expectation is one of the very important topics that we must, first of all, understand accurately, and also should include when we are conducting any training program for healthcare professionals. Because most of the times, if you are an organizer, or if you are working for an organization who call you for a program, they will expect you to talk about this particular issue with the staff, because they somewhere have this feeling that patient expectations are not accurately understood and not addressed properly. So my question to all of you is, what do you think about patients' expectations? Share your thoughts in the chat box. If I say patients' expectations, what are the immediate thoughts that occur to your mind? If you could write in the chat box. Are they realistic? Are they unrealistic? Are they demanding? Are they not met? Are they met? Whatever comes to your mind, please write in the chat box. Mechanical versus actual need. Okay. So I would ask you to elaborate on it, Dr. Akshita, but let everybody respond. Then maybe I'll ask you to unmute and share your explanation. Yeah. But by then, if others could write. If I ask you this question, what do you think about patients' expectations? What thoughts come to your mind? Write them in the chat box. A lot of time we get to hear this patient is really very demanding. Okay. Pritaji says it's actually an empathic need, as they are troubled and distraught. No doubt about it. Savita Rao says, from the patient's perspective, it is realistic. Agreed. Most of the times it is not met. Agreed. Quality care, I think, that can really serve them. This is what Nabidita says. And Dr. Tanu says that one of the expectation is they want to be heard, they want to be listened. I completely agree with you. So, a lot of time, patients would have an expectation that's unrealistic. How do we address that? Have you ever experienced when patients have some unrealistic expectations? Any situation, if you can recollect? Okay, Chandana says by counseling you can. Yes, I completely agree. I think communication and counseling is the only way to address it. But how many of us are successfully able to address that? That's a question to be asked. Okay, so what are the common?
May I answer?
Yeah, please. Yeah.
Yeah. See, when we say that a patient's expectation is unrealistic The only way probably we can do, as Dr. Sanu has said, is to listen to them. Once we listen to them and understand from where they're coming, allay their fears, because most often it is fear that kind of, makes them react the way they react. For a doctor, it is a very familiar surrounding, but for a patient, it is, there are so many mixed feelings apart from the suffering, whether it could be of self or the family member.
Yeah.
So when you come from that point, the least that can be done is for a patient hearing, and then maybe through the listen, when you listen to the patient, doctor would find it, very simple to actually understand which are the pain points or which are the areas that need to be attended to, and once you allay the fears, the patient should be fine.
I agree with you, Dr. Kavita, what you're saying. So a lot of time, like in a couple of my programs, some of the doctors shared their experience that it was a very well-placed hospital and corporate hospital. The patient was admitted in the ICU in a very critical condition. The relatives were very well off financially. So they literally came to the doctor and said, "Doctor, how much ever money you need, take from me, but save my patient. Otherwise, he had gun in his pocket."
Actually, yes, of course, this is an extreme thing, but we often encounter situations where they are not willing to hear that, yes, patient may not survive.
Yeah.
So
again,
I mean, even if you're telling them repeatedly that patient is sick, you can't actually tell them, look, this patient is going to die. I mean, this is not what you can tell them. You can just keep telling them, he's very sick. We are trying our best. He has this. I mean, after you have told them he has infection in the blood, he has infection in the brain, his kidneys are shutting down, and still they will say कि बच तो जाएगा ना. And you can't tell them कि नहीं बचेगा नहीं. अगर हमने यही कहना है कि बचेगा नहीं, then why are you even keeping them in the hospital? So,
Dr. Kano, this part that you're saying, I completely empathize with you, what you say, and this is what we very often, doctors find difficult to explain. But then there are a lot of ways that we will be talking in one of these sessions in forthcoming sessions, where we talk about the how do you handle uncooperative patients or who are not able to understand your point of view, and their assertive communication plays a very big role in helping them see what is right. And I'll be giving you a couple of demos also to help you see how you have to make them understand if the condition is like serious and why it is important to maybe in a very upright, polite, but firm manner communicate. See, whatever best can be done is being done, but then prognosis is poor. If you wish to take second opinion, feel free to take second opinion. If you want me to write a summary of your patient, and if you want to take that summary and talk to somebody, go ahead and do it. Absolutely, we are open to the idea. If you want me to speak to any of your doctor who is known to you, I'm ready to explain to that person so that you know clearly that this is what it is. And I think this is one bottleneck that leads to aggressive reactions, where we have not been able to, in a very clear, upright manner, tell to the patient's party that prognosis is actually poor. We fear that if we say that, they might take away the patient, they may refuse for continuing the treatment, but we have to come out of that fear. And that's the gray area that leads to aggressive reactions, because we from our side have communicated the condition is not okay, but the family is still under this impression it's serious, but there's a possibility. It's serious, but it's a possibility. So that means we have not been able to clearly communicate. And I think this is one art as doctors we have to learn. We have to call a sheep a sheep. That's the only way. And we'll be talking about it in a detailed manner. How do you go about asserting yourself? So we'll be spending good 2.5 hours just on this. How do you assert and you make your point clear? But I completely empathize with you. This is one of the greatest bottleneck. And then that leads to a lot of aggressive reactions we get from the patient party and the community on the whole. So coming back to the patient expectation, as I deliberately asked this question, unrealistic expectation. So this is an unrealistic expectation. When we know the prognosis is poor, but the patient family says, take as much money as you want, but save my patient. We can't ignore this statement when it comes. We got to sit and address. I wish I could promise you with this much of money, I can save your patient, but I don't have any way out. I don't have any calculation that can tell you that this much of money can save your patient. That means I have to even address this unrealistic expectation. So a lot of time we just evade it. We don't like to talk to that person who has unrealistic expectation, but sit and talk to them and address them. That's the idea I want to float here. And that's why we are going to talk about understanding patients' expectation. So how are expectations of patients of a government hospital and patients going to the private hospital, how are they different and why are they different? I'm sorry, Dr. Rakshita had something to say. Sorry, Dr. Rakshita, I missed your point. You wanted to say something.
I was only giving that reference about mechanical versus actual because during COVID time, we actually started off with the process of checking the temperature and everything, right? So it became a very funny act to be observed because there were those, separately there was those tents and all kept where you had to go through the screening process. Okay. However, now of course the hospitals have removed that. So when we were actually mapping the processes, so the security guards were given those guns to map the temperature. Okay. Now in that fraction of seconds, I mean, it is visibly clear that that guard cannot check the temperature, cannot do anything, and the purpose with which a person is visiting the hospital is sickness. Okay, and just because that guard is told to check, even to a small kid, that guard is, showing the gun without even looking at it, what is there. So that is what I meant by doing a mechanical process versus the actual need with which a process is introduced.
Yeah. I agree. I understand a lot of time we do things for the patients, but they are done in a more mechanical manner and there's no human factor, included. And that really upsets the patients and everybody actually for that matter. So
I would like to share my personal experience with reference to this mechanical and actual, if you may allow. Yeah, like because about a year and a half, I underwent a total hysterectomy in one of the most reputed hospitals here in Bangalore. And after the process, the only thing I don't know whether this comes under too much of expectation, but after I came to my senses, post anesthetic effect, I was just hoping that, that my doctor, who had actually performed the surgery and who was actually under whose care I'm supposed to be, that she would come and talk to me for at least a couple of minutes and give me the assurance that, okay, fine, everything went as expected and you'll be fine. I'll see you later tomorrow. Just these 2-3 sentences. Fine, but that didn't happen. And I was going through certain discomfort. And when I just asked the sister and the hospital administrator, they said that she had left for the day. And that was kind of, I didn't expect that. So it was very, I just didn't know. I was angry and there were so many other things that happened. And the doctor who assisted her, he was not of that hospital. He came from outside. But then he came and he sat by my side for at least 10 minutes. And he explained how the whole thing went. And, kind of, giving me that reassurance. And that made such a huge difference to know that, okay, fine, whatever was done inside me is going to be okay. So that's where, for me, it meant a lot. So this is, I don't know whether doctors would put it like, for them it was mechanical because it was another case in a day.
So a lot of time patients would have a set of expectations, like Professor Savita is sharing her experience. Are we sensitive to those expectations? Are we addressing them? Are we meeting them? Are we sending them satisfied? I think that's what is the crux of today's topic that we are going to discuss. So my question to all of you is, how is this set of expectations people have from a government hospital setup and a corporate hospital setup different? How are they different? Can you think and write in the chat box? So what do you think is the difference between the two set of expectations and why? Just think and write in the chat box. Dr. Savita, your screen has gone oblique. If you can make it, I don't know what is the reason. Yeah, this was no. Again, it's gone oblique. Yeah, this is okay. So if anybody would like to, Dr. Kunal, are you familiar with what we are talking?
Yes, ma'am, a little bit about patient expectations, and we were discussing something about realistic and unrealistic expectations.
Yeah. So we were talking about the expectations of patients and how are two set of expectations different, people visiting government setup or the private setup, because then we need to understand how we need to really meet those needs. Okay, so I think Chandana has written, in government setup there's a kind of reluctance towards patients, maybe because of overload patient flow. Chandana, what I'm looking for is from the patient's perspective, what are their expectations? If the patient is visiting a government setup, what do you think are the kind of expectation the patient will have? And the patient who visits a corporate hospital, so what are their expectations? Dr. Savita says probably in a private setup, the expectations are high, maybe a sense of entitlement. Agreed. Dr. Arjun says in private, they expect minimal waiting time. Yes, they are very particular about waiting time. Okay. Preeta ji says no expectations versus enhanced expectation because they are paying for it. And health point of view, expectations are same. Yes, more or less they are same, but then service point of view, yes, it's very different because they are paying and they want value for money and value for time. So probably people working in government setup may not experience that much of challenge. Okay, Dr. Tanu says in government setup, people just expect availability of service and health personnel on arrival to hospital. But in private hospital, expectations are much more because of usually better social economic status. I completely agree with you, Dr. Kano, what you have said. Chandana says most of the patients who go to the government hospital are normally from economically poor background and who have less awareness. So expectations are automatically less. I think you are also endorsing Dr. Tanu's point. In a government setup, owing to their financial circumstances, they are glad to receive any kind of help. Absolutely, I think I agree with all of you that usually in a government setup, most of them will have very minimal expectation, and that will be mainly that kindly see me, write me some medicine. If I need admission, please admit me. If I need surgery, please operate me. That's all. But of course, in corporate setup, in private setup, since they are paying, their expectations are different. And as a result, when their expectations are more, we are more accountable also. We are more, under kind of vigilance. Any error at our end can be very, very, dangerous and can lead us into problem. It could be legal problem. It could be violence against us. It could be anything of that sort. So if I say this topic of understanding patient expectation is important. So how do you think discussing about this with your audience, you think you will be able to kind of highlight a couple of points? If you can unmute your device and share your thoughts. Suppose if I say this topic is important, so do you agree with me, and how is this going to help you if you have this as a topic? Anyone? Dr. Kunal, would you like to answer this?
If we discuss with, depends on the audience with which we would be talking. So if we start discussing this topic about patient expectations with the clinicians, the initial point of view would be that we are doing good enough considering the treatment part, what we are doing. So I think we are meeting their expectations, and that is why we are getting so many patients. It would be the first response that I would suggest, I would get. And if we and rest of the things which do not fall in that purview would be unrealistic from their point of view.
Yeah. If patient expects me to treat them well, talk to them nicely, offer them seat, so I'm not going to do all this. That's not something I'm here for. And here I'm here just to treat the patient. So that means from the doctor's point of view, I am treating, that's more than enough.
Yes, and that is why people are coming back to me. And
so in case if you need to take this topic with clinicians, can you think of any pedagogy that would help?
I think most of the clinicians' family members would be patients in the same hospital or some other hospital. So maybe experience sharing, which would be a good idea. If I can get through some of the clinicians who can share the experiences, if I can discuss with them beforehand, before the session, and try to understand the experience of their family members, maybe in the same country or maybe abroad, and where they would mark a difference in the type of services. And there would be many clinicians who are working from different organizations, who have worked from different organizations before coming to ours.
Yeah.
So they can mark a difference, and then maybe I can align them with my ideas and try to get through the experience share.
Thank you for the response. One of the very good ways to bring anyone and everyone to a point where they get into self-reflection is case studies. Even management schools like Harvard and IIM, they don't teach management topics, as such directly, because I think most of these topics everybody knows. If you try teaching them motivation, leadership, conflict resolution, and whatever, like we talk in management, they would say we have read it, we already know it. And one of the best ways to help people, critically and creatively think is get them into the mode of self-reflection. So case studies is a wonderful way to pick up situations and then help them see what they did wrong and how it can be done differently. And there you are actually making them self-reflect without making them get into that guilt of me to have done this. So just yesterday, I was speaking to a very senior gynecologist, and she was sharing her pain of, errors that her residents are making under her nose. And she says, I leave a patient in labor with minimal risk, with no history of any kind of, obstruction or any obstetric, history. And the next day, when I go back in the morning, I either get to hear fetal death or maybe mother in distress or mother in ICU. She says, I get completely shocked seeing these things. And I really feel so bad. It's more like, I am also a murderer with this resident. These were her words that she shared with me. And she said, I really do not know how do I make them see the mistakes they are doing. Then I suggested her, I said, adopt case study technique with them. And that's one of the best ways to bring them to self-reflection mode. I said, don't blame anybody. Don't name the doctor. Don't name the patient. Don't name the unit. Just say, this is case, this and this. This is what exactly happened. This was the management done. What do you think where we went wrong in terms of management? And now she's going to take this up as a main way of, teaching her residents and also, bringing them to a point. So case study is one of the best ways to bring your audience to a point where they start self-reflecting. So let's do one case study today to see how we can use this as a pedagogy to help people understand patients' expectations. So I hope you have all read the case studies that I had shared with you. If any one of you can open your document and go to page number 34, where we have case study 1. Yeah. Has anybody got it printed? Anybody who got the?
Yes.
So you'll have this physical copy of it with you. No?
I have it on the screen.
Okay, you have on the screen. Yeah. Okay. So will anybody take the responsibility of reading at least first 2 paragraphs? Then we can turn by turn ask others to read. Yeah, page 33. Dr. Rakshita, thank you. Page 33. Please go to page 33 of the document. And if somebody could start reading this case.
Okay, I'll do that.
Thank you, ma'am. Thank you.
So ready, set, go. Right after dinner, Abdul Rahman clutched his chest and told his wife, Zeenat, that he thought he had a heart attack. Zeenat wasted no time getting Abdul and their 16-year-old daughter, Katrina, into the car and raced to a nearby hospital. Although the ER was quite busy, Abdul was placed in a room immediately and attended by Dr. Raghavan and the nurses on duty. After taking the history, the team checked his vital signs, including pulse rate, blood pressure, breathing rate, temperature, and auscultation. All preliminary tests were normal, and Abdul noted that his chest pain had also diminished. I'll be back in a while, Dr. Raghavan said. The nurses also left the room, going outside to take orders from Dr. Raghavan. Should I continue?
So if anybody else is willing to read further, that will be nice, because for anybody to read completely can be a little tiring. Anybody who has the document?
May I?
Sure, please. Sure. Yeah.
Yeah, I have it. May I?
Yeah. Please,
Yeah.
please.
Okay. Yes. 2 or 3 times during the next hour, one of the nurses looked into the room, scanned various instruments,
Dr.
and
Savita,
left.
you missed a paragraph. After
Okay. Zeenat held Abdul's hand while he was still lying on the examination table. Katrina began to cry. Dad, this is scaring me so much. I don't know what I would do if anything happened to you. I'll be fine, Abdul replied. I'm feeling much better already. I bet they'll let us go home very soon. 2 or 3 times during the next hour, one of the nurses looked into the room, scanned various instruments, and left. Another hour passed, then another. I think they forgot you were here, Zinat said. They know you're fine, or the doctor would be checking on you. I'll find someone and see if they are finished with you now. I'm getting impatient, just sitting here with nothing being done and no one telling us what's going on. Zenith went to the large circular desk in the middle of the room and asked a nurse if it was all right for Abdul to leave, since they had been in the room most of the time alone for quite some time. I'll ask Dr. Raghavan, a nurse said. It may be a few minutes. He's with another patient. We might as well leave. He's feeling better, and there doesn't seem to be a reason to sit around here, said Zenith. Would anybody else be reading, or should I continue?
Okay. Will anybody take the responsibility of reading further?
Ma'am, may I?
Please. Yes, Chandra, go ahead.
When the nurse saw Dr. Raghavan, she asked him, Doctor, Rahman's wife just said that they want to go as nothing is being done, so he must be fine. She thinks that they should leave. That is ridiculous, said Dr. Raghavan, almost shouting. So she is bored and wants to go home. Tell that female that this isn't about her and her comfort. It is about the patient. Tell her no. I'm not releasing the patient until we have completed our monitoring and we are certain he is not at risk. Katrina had wandered outside of the exam room moments earlier and couldn't help but hear this entire conversation through the conference room door. She went back to the room and said, Mom, it sounds like the doctor is pretty mad at you. You are kidding, Zinat said. What for? He thinks you want Dad to go home just because you are tired of sitting here and that you don't seem to care whether Dad is well or not. He told a nurse that they were still monitoring him. They're still monitoring him. How did I know? No one had spoken to us for hours. He just left us in that little room. I think I'll have a word with the doctor. Just as she spoke, Dr. Raghavan entered the room.
Thank you. Thank you, everyone. So some of the discussion points that are given here, these can be used for discussion. For example, should the Rahman family have known that Abdul was continuing to be monitored?
Of course.
But how would have been known?
The nurse or the doctor could have explained.
Exactly. But do we really explain them?
No.
Usually we do not explain them. Usually we take it for granted that patient will wait. We don't have to communicate what is the plan of action or what we intend to do. See, a small communication when you're leaving the room, and if you are able to say things look okay, but we need to wait and watch, and we need to keep him under observation for next 24 hours or 10 hours or 6 hours or 12 hours. So a small communication can actually, make it clear to the patient that this is the plan of action. So is this expectation something very unusual or unrealistic?
No.
Actually, no. But then we don't meet this expectation and we don't care to inform. Why do you think we don't care to inform? Can you think of the reasons? Maybe you can write in the chat box. Why do
From the
you
doctor's perspective, as I said earlier, even in my case, it is a routine thing. Because it is a place of work, they're coming there every day, they're seeing so many patients, all of them suffering with various diseases. And this patient is also a number to them,
one of them?
another one. But for
So,
the
Dr.
patient, it
Savita,
is not a number.
yeah. So I am sure many of you will be very well versed with the term patient-centered practice. There was a time when it was a doctor-centered practice. Everything, all services, all facilities, all infrastructure was keeping the doctor in mind. What do the doctor want? What will suit the doctor? What timing will suit the doctor? What will be, comfortable to the doctor? And what is doctor's point of view? That really mattered. But it's been long since we have moved out of doctor-centered practice to patient-centered practice. And wherever we are not keeping this perspective in mind, I think we are facing challenges. I don't know how many of you have got a chance to see the anonymous feedback that is taken from patients of government hospitals under the title Apna Aspatal. In that, they are very okay with the services, they are very okay with the facilities, but they are very un-okay with the behavior and communication. That's because we are still moving with the same mindset where we think whatever we decide is the final word for the patient. And we don't even have to communicate that word to the patient. And if we don't understand this, we are not sending our patient satisfied. Now, next question is, why don't we inform them properly? Why do you think we don't inform them? Just write in the chat box I think that everybody will get a chance to express their thoughts.
Ma'am, can I share a personal experience?
Okay, go ahead.
So recently I had my spinal surgery. So I was in the pre-op and, they were taking longer time also because, there are some emergency cases and my procedure was elective one. So the doctor informed me, but I asked them, to inform my family. Even though half of my family are doctors, yet they got really scared when they saw that, I'm still in the pre-op after, 2-3 hours. So and they were not informed. And it was a, highly decorated private hospital. So it was kind of a disappointment on my family, but they got really scared. Something happened to me.
And see, when these communications are not made, people continue assuming. And those assumptions are more often negative than positive. And in case if something goes wrong, chances are that their assumption has either become true or it has fed the situation, and there can be more negativity and aggression in the air. Okay, Savitaji says most often doctors assume that patients won't understand, so let us not complicate matter for them. I completely agree. We think it's too technical for the patient to understand. Even if it is too technical, can it be made simple? Can it be explained in a manner that it is understood by the patient? When we watch so many dance performances, in 1 or 2 minutes, they are able to talk about the whole story of a movie. Can we develop those communication skills where we can tell them what is what? What are the other reasons? Why don't we inform them? Like Dr. Savita said, that one of the reasons is they think that they will not understand. But why do we not normally inform them? Do we take them for granted? A lot of time. A lot of time we take them for granted. Do we value their time? Do we value their visit? A lot of time you personally must have experienced, you went to see a doctor and the doctor was not there. It was a planned leave for him, but you were not informed. You wasted your whole day visiting the doctor and you came back disappointed because you were not informed. So a lot of time, simple proactive communication can help you prevent these kind of mishaps in communication. Okay, there's another reply from, okay, Savita ji. They don't want to make the effort to simplify the condition. Quite possible that they never know the importance of this communication, or because there is no communication training. There's no communication training, so a lot of time that can be a reason. We don't know how do you really put that across to the patient. I completely agree. Okay.
Actually, it is true, madam, because that is what I was told. You know, for them, it has never been part of their learning. That you know, earlier we had something called as a bedside manner for a doctor. Well, that was a time long ago when we had somebody called as a family doctor. And the person, you know, family doctor, he was like a family. And there was something called as a bedside manner, how you would talk to a patient.
So you'll be glad to know, Dr. Savita, you will be glad to know that MCI, that is now National Medical Council, have introduced a module called ATCOM module, Attitude, Ethics and Communication module, that is integrated with the undergraduate training now. So right from the year 1, they are working on developing the right attitude towards their profession, towards patient, society, and their work ethics, and also the required communication skills they need to imbibe right from the beginning. So hopefully the next generation of doctors, maybe 10 years down the line, you will find them more communicative and more responsible when it comes to it, because this was not part of their training. So many of them who already had good communication skills, they did very well, but a lot of them are usually very quiet and introvert and are not open to the idea of communicating, and also patient never demanded this from them. Patient viewed them as God and also assumed that they are the one who would decide, and they are the one who will decide in my best interest. So I need not question his intention. So we have to see the background and see how from where it is coming. Again, I would not blame them for the failure. I would say, rather than blaming them, empower them with the right tools and techniques of how do you go about, communicating proactively. Second thing that I always emphasize for those of you who are into hospital management and are at the executive position, a lot of time your consultants will not mend their ways because that's what they are. And they may say, this is what the way I am conditioned. And it sometimes becomes very difficult to even work on changing them. I will recommend proactively compensate for that deficiencies by having proactive communication environment done by all others other than the consultant. So a communication a consultant refuses to make can be done by the resident, can be done by the nurses, can be done by the managers, can be done by quality people, can be done as a systemic communication. And that can really, fulfill the need. Rather than blaming that they don't do it, we can find a way how can they be communicated. I think this is something I always recommend. Okay, so how did the expectations of Rahman family change during their visit to the emergency room? I think this is a very interesting question we need to ponder on. How did the expectation change?
I think initially they just wanted to be attended to, and that happened immediately. So they were attended to, and then Dr. Raghavan, he attended to them and he said, I'll be back in a while. So they kept expecting him to come back and tell them what is happening. The nurse came 2-3 times during the first hour, but after that, for another couple of hours, she did not come in. So they kept wondering what is happening. And since he was feeling better, they felt, okay, maybe we should go home now. There is nothing to do because If they're not
Absolutely.
coming, that means there is nothing to worry about.
Absolutely.
So,
So that means when the patient would come to your emergency care area, the expectation is immediate care. Look after my pain, look after my suffering. If I'm bleeding, please control my bleeding. If I'm having fever, please help my fever come down. If I have pain, please control my pain. But once that is done, the second expectation would come in place. So how many of you have read about Maslow's theory of motivation? Have you read about? Okay, Dr. Savita has read. I'm sure
heard
Chandra
about
knows
it,
it.
read it briefly.
You have read it. I'm sure Chandra would be knowing because that we use a lot in counseling. But just to tell all others, Maslow has very beautifully, explained about the needs that we all have that come into action from time to time. Okay, Dr. Rakshita also, I'm sure you would be knowing because you are also from a mental health background. So if you look at the pyramid, the most important need that is always in action is the basic need. And basic need is all about your physiological needs. Air, water, food. So whenever you are troubled with these needs, you come to a hospital that either you are not able to breathe, or you are in pain, or you have some gastric issue. So definitely that's the first need that you want to be looked after. The second order need is safety need. So these two needs go simultaneously hand in hand. Once these two needs are met, the next order need is that they want to be communicated. They want to be involved. They want to be engaged. They want to be informed. If we understand Maslow's theory in a right manner, we would understand once we have been able to provide first aid to the patient, once we have been able to reduce the suffering, the next order need is that they want to be told what next. How are we going to deal with you? What are we going to do with you? What is the plan of management? Earlier, plan of management was our prerogative. It was never shared with the patient. And even if it was shared, it was more like a dictum. Surgery hogi, admission hoga, operation hoga, and that's all. IV lagega. And that's all. No discussion. But today, patients are educated. They are paying for this service. They can Google search. They have an idea about other options available. And they're also fearful that I may be mistreated or wrongly treated. So I need to be 100% sure that I'm getting the right treatment in the right manner. So out of all this, definitely they would like to be explained. So is this something abnormal? If I talk about, is this something abnormal expectation from the patient side? Actually not. Actually not. Only thing is, if we can understand what could have been done, it would have been very, very easy. Dr. Rakshita says they understand target completion. Okay. There's nothing wrong even in target completion, but it has to be done in a legitimate manner, in a right way, in a fair way. There's nothing wrong in having targets and meeting your targets, but it shouldn't be fulfilled in an unfair manner. I think that's something we need to really ponder on. So what behavior of the physician and the nurse affected the patient and the family? What do you think? Although I know Dr. Tanu has answered this question in a way, but what all behavior do you think really affected the family, patient and the family? Dr. Raghavan said, I'm coming back in a minute. So that was his way of going out, isn't it? The nurse went into the room a couple of times, and we see nurses going in and checking on the monitor, checking on the IV, giving medicine. How many times do they talk to the patient? How many times do they really ask the patient, do you need anything? Are you all right? Do you have any question? Do you want to understand something? And these are very simple communication, which won't take much time. But making that connection is so very important. And what could have been done differently by both doctor and the nurse to have avoided this misunderstanding? What could have been done? Simple.
They could have just told him that we are monitoring him. So
Exactly.
we'll need to keep him for a couple of hours.
Yeah.
And probably like Dr. Raghavan was with other patients, so probably he had another emergency he was attending to, but the nurse who came 2-3 times, she could have told that.
And if you observed the way she went and informed the doctor about the patient's wife coming and saying that can we go home, and how she changed the version of communication. Did you observe that? A lot of time we add our own thoughts and feelings into communication and distort the communication. Did you see the meaning of what she said? She thinks nothing is being done. Nothing is being done. She never said that nothing is being done. Somehow, sometimes even this would aggravate the condition. Also, how did the doctor react? How did he react? He literally shouted. He said, ridiculous. What does she think of herself? It's not about her. It's about the patient. Tell her, no, I'm not really. Full of
biasness towards the female, because he said that till that female.
Yeah, yeah. A derogatory way of addressing a person, not a desirable way of. So you can see how the patient's expectation change, and we got to be mindful of those expectations and integrate those expectations in our services that we are providing. So there are a couple of more case studies, which I will not take further, but you can use these case studies when you do programs in your setup. You could even create a case study from a situation that has happened in your hospital and you think that's really bothering you. And you could throw this case study as an activity to your audience and ask them to creatively and critically analyze, and you could ask some pertinent questions to check how could have this been done differently, what could have been done to not have this result. So case studies and followed by Socratic questioning is a wonderful way to introduce a concept when you know directly you cannot address, especially something like patient expectation. They will usually say, well, they have all useless expectation. They think money can buy everything. They think we are their servants. They treat us like this. So all that is like more like, a passive aggressive kind of an explanation, which is not desirable. Okay. So I would not go into these studies. And one of the very interesting case studies is the last one, and that is extra package. If you can have a look at it. Again, no, sorry, I'm so sorry. No, yeah, extra package you can. This is one study I want to talk about. This exactly happened with me. This I have personally experienced. My father was admitted to in one of the very well-known hospitals of Delhi for cardiac surgeries. He was admitted for bypass surgery. Surgery, went well. He was recuperating very well. On the 3rd or 4th day, when he was still in the ICU, I had gone to meet my daughter, who was stationed somewhere outside. So I had gone to meet her. And on my way back, I received a call from the hospital. And it was the cardiac surgeon, a very senior cardiac surgeon who had operated upon my father. He said, your father is very agitated. He's acting very aggressive, and we are not able to hold him in the ICU. So we are shifting him out, and we are shifting him to single room. Like we had opted for a package where after his ICU stay, he would be moved to a room where there were two patients could be accommodated, 2-bedded room. I said, okay, if you think that's the need of the hour and I'm not there, so I leave it to you and you can, shift him wherever you think it's right to shift. They moved him to a single room, and I'll share another experience beside it. To my surprise, when they billed us, the whole package was completely changed just because on the last 2 days he was admitted in the single room and not moved to to a room with 2 beds where that's what we had. So when we do something like this, and then we expect the patient and their family member to quietly pay, I think we need to introspect. You're taking your patient for a ride. I mean, I felt cheated, honestly. I went and talked to them. I said, that's all right. If you want to charge me whatever your charges for single room are for 2 days, I'm ready to pay. Even if it is difference of 10,000, 20,000, I'm okay with that. But you can't change the complete package by 50,000 and 75,000. And second thing, which was very sad, was when I reached, within hours I was there. When I reached him, I asked my father, I said, what happened? Why are you so aggressive and agitated? The moment he started talking, I could know immediately that it was ICU psychosis. It was ICU psychosis. Anybody who would be in that position can experience. And I asked the staff, what happened? What exactly happened? They said, ma'am, he's abusing us, he's shouting at us, he's doing all these things. In psychosis, you are not in your senses. So patient would be not having any insight of the behavior. They started with the medication, but they were ridiculing. They were making mockery of what he was saying. And then I asked what happened. I asked my father. I said, I'm asking them for a cup of warm water to gargle. That is his habit for years. The moment he will get up, before taking a cup of tea, he would take a glass of water, he would gargle, and then he would sit and have a cup of tea. And these people are saying, chai pilo, chai pilo, chai pilo, and they are not ready to give me that 1 cup of warm water. I immediately arranged for warm water. He did gargles. He took his tea and his breakfast, and he was free. So a very sad thing, being ignorant, how do you manage such patients and address their concern? And I was disappointed as an attendant. And I think the next case that I want you to really use in case if you have similar situation in your setup, and that's about the brand new unit. That's case study 4. And this case study is about a patient who is in stage 4 cancer, and you know you will not be able to do much, but more than focusing on how you can palliate the patient, you're focusing on talking about the brand new unit that you have built in your hospital to accommodate such patients and to provide them comfort. And you're talking about these services. I don't know how many of you have read this case study. Did you read? What thoughts you had after reading, if you may share?
I did read it. Actually, I read all the cases.
Okay.
And I just felt that, those words, empathy was totally missing. And I won't use the word insensitive, because somewhere it was not, the doctor was not being intentional about it. He didn't realize that, he was actually missing the point. What was the
so I will not call it
or the patient's relative.
It is
no, it was not insensitive. Yeah,
I
it
would
was
say lack of sensitivity.
he was not insensitive. It is empathy.
Yeah.
I would say lack of empathy, actually, what I would say, because he just couldn't relate to the patient's relative.
Right. Yeah.
So, like they were on 2 different tangents they were talking.
Absolutely.
She was wanting something
Absolutely.
and he was talking about something.
Absolutely. So I think
They
these
were both on
studies
the same page, basically.
Exactly. Exactly. She could not understand the suffering of the family and not being able to accept the outcome and was not ready to move to the next stage. The therapist could have given time and opportunity to express and to address it and to make it comfortable for the patient's family to understand that this is what it is. And we'll be talking about...
I can relate to this. Sorry to interrupt. I can relate to this because my mother suffered from cancer and we were in Tata Memorial Hospital and I had the doctor. When he finally, after the operation, he the way he communicated the news, like there is nothing that we can do at this stage except hope that the rest of our days are as peaceful as possible. See, for a doctor to say this, it's huge. And for a patient relative to hear this, it's huge.
It's very,
You
is a
are
different
giving
impact.
time for
Different
you're giving the patient's relative time for the situation to sink in.
Yeah, exactly.
And usually the patient's caregiver also goes through a lot while caring for the, especially in such cases, in such terminal cases.
I completely agree.
So it's not just about treating the patient. You have to be sensitive to the caregiver also, which is, many a times, I'm sorry to say, I'm talking in front of so many doctors, many a times it is missing. But thankfully in Bombay, we had that kind of a doctor. So it was okay.
I agree. So let me quickly share my screen with you and discuss patient's expectations in detail with you a little more. Just 1 second, give me a second. Okay, there we go. I hope my screen is visible to all of you. It's loading. Yeah.
Okay. Yeah.
So, according to a recent survey by ICC, CRMA, and Tranmate, 2019, 45% of the families reported feeling unempowered in the treatment of their patient. They expressed inadequate clarity on diagnosis, reported rushed consultation, and perceived lack of involvement in deciding the treatment, and lack of clarity on treatment and care options. So that should tell us that almost like everybody wants these details to be shared with them, but we do not actually honestly address this and share this with them. According to the same survey, 35% of the patients indicated that they were not allowed to describe their conditions or symptoms. 32% of the patients indicated that doctor did not straightforwardly address their questions and doubts. So that clearly shows that we really need to work on our communication skills, where we need to address their concerns, and we need to learn to say, even if we have to say no, or poor prognosis, or deterioration, or whatever the condition is, in a manner that goes clearly to the family, not in an insensitive manner, but in a straightforward manner. So I want to introduce you to a model called Kano's model. How many of you have heard of this? Has anybody heard of Kano's model? So Kano's model says that the expectations of your clients or your patients can be divided in 3 categories. The first category is basic. So when we talk about the basic expectation, these are unspoken expectations expected to be satisfied. So anybody who will come to you for any services would have these expectations, and they would expect these expectations to be satisfied. So when these expectations are met, they would not acknowledge, because that is what they are here for. But when these expectations are not met, client is dissatisfied. So can you think of any basic expectations that the patient would have which need to be satisfied? When they are not satisfied, they'll be unhappy. Can you?
The doctor listening to them properly and understanding their concerns.
Okay, but much more than that, something like I'm treated.
Being seen by a doctor.
Being seen by the doctor, yes. Seen by the doctor. Examined properly, or the right diagnosis. Or for example, if the patient has come for lab services, at least your lab is a standardized lab. Your reports are something that they're at least accurate. Or if the patient is admitted, at least you are providing them a room or a place to sit. So these are all services that are must, If they are met, patient will not tell you, thank you for examining me, thank you for treating me, thank you for admitting me. But yes, when they are not met, they would make a note of it and they'll be sad about it or upset about it. So all these needs will come in the basic category. The second category is satisfiers or performer. So Dr. Preeta, the one which you were saying, when the doctor listens and talks to the patient, this is something that if it is done, the patients feel good and happy about it. So these are the expectations when they are met, client is satisfied and happy. And when they are not met, again, client will be dissatisfied and unhappy. So can you think of some examples that when we do, that really satisfied the patient, but if they're not done, they feel bad about it? Dr. Arjun, can you think of any examples that will fit in this category?
Ma'am,
So
this is like
all the
something
basic
like
courtesies.
Delight, patient delight. Does it come that?
That's next one. That's next
Okay.
one. That's level 3. So all the basic courtesies, all the professional etiquettes, all the professional protocols, when they are followed meticulously, they all act as satisfiers. For example, if the patient has come, and if I welcome the patient, talk to the patient properly, offer the place to sit, and make sure that the patient is attended promptly, and whatever the services patient needs, they are provided, all this will be a performer or satisfier kind of expectation. So greeting the patient, welcoming the patient, offering place to sit, having a neat and clean toilet, providing a neat and clean room, AC is functioning, cleanliness, ambience of the place, all this is part of performer. They are expected, especially if we talk about a corporate hospital. This is something every patient will expect. A patient going to a government hospital will not expect a neat and a clean, washroom.
Yes.
But patient coming to a private hospital, corporate hospital, for them that is something that has to be there. But if it is there, they are not like very gaga about it, but then they are satisfied. Okay, this is a good hospital. So all the basic courtesies, etiquettes, listening, dealing respectfully, providing them the comfort, giving them the services that they require, they would all be part of the satisfier or performer category. The third category is delight or the delighter, what we're talking about. So when the patient's requirements are there, but the patient does not expect to be fulfilled, when they are met, it becomes a delight. For example, as of now, I don't think we are regularly communicating or informing the patient that doctor is not available on this date. So in case if you have booked an appointment, please don't visit. Do we do that? Do we do that in any of the hospitals? Namita, in your hospital, Savita ji, or Preeta ji, anywhere you have seen, if the doctor is not in the OPD or he's not going to be there, do we inform the patient? Have you ever received a message from any hospital? Okay, you have an appointment with us today, so your appointment is cancelled because the doctor is not there. We need to reschedule your appointment.
Yeah, I have received.
Wonderful. So how do you
from
feel?
Fortis, yes.
So how do you feel when you receive this communication?
It feels good. Yeah.
You
feel good and at the same time disappointed.
Yeah. But at least
that
your
you
visit
couldn't
was
have your
saved.
appointment. But then you feel no, yes, definitely. There is a relief, but that's where it is. At least you could save the trouble of traveling.
How many of you receive a message from your electric suppliers? Like in Delhi, it is TDDL, Tata, how many of you receive message from them? The electric supply to your area will be, cut from this to this hour. Sorry for the inconvenience. But if you received, how many of you have visited?
In Bangalore, we have it in the newspaper.
Yeah, wonderful, wonderful. So in Delhi, we receive as a message on our phone that the electric supply to your area will be disrupted from this hour to this hour. How many of you have visited passport office recently, especially the ones managed by Tata? Anybody who has visited the passport office in the recent past, maybe last 5 years or so? If you happen to visit, you will actually feel delighted. They have actually worked very meticulously on making sure that your visit to the passport office is a delight. Minimum waiting time, earliest response, quickest service, and in case if you have any challenge anywhere, there is somebody to address your concerns. So healthcare services are working on the area of making it a delight for the patient and their family member. So my encounter with this concept in healthcare was somewhere around 30 years ago, when my husband's aunt was admitted in Escorts Hospital, Delhi. So it was Dr. Trehan, if I'm not wrong. It was Dr. Trehan who had started, now he's in Medanta. Yes, he was so when I went to visit his aunt, my husband's aunt, the hospital looked more like 5-star hotel, and huge waiting areas, huge coffee shops for the attendants, bookshops, toy shops, gift shops, cafeteria. I mean, I was shocked and surprised, especially at that time I had not seen any hospital on those lines. So I was really surprised, and to me it appeared to be something like extravaganza. But today when I look back, I look at it from a very different perspective. That family, when they're attending their patient, they're waiting outside for hours, for days, without any basic facilities. So why not, if they can afford, if you can arrange for those services, or at least on the similar lines, to make their stay comfortable, to make their waiting comfortable, to have them place to sit or rest or eat or use washroom. What is wrong in it? So now I see, I think every corporate hospital focuses on not just the patient, but also on the attendants and the comfort of it. So delighters are something that the patient needs, but does not expect the hospital to fulfill. But when you fulfill it, it's a delight to them. It's a delight to them. So I had admitted my bhabi in one of the hospitals for her bariatric surgery. And incidentally, it happened to be her birthday. They normally write all details of the patient, and they must have noted the date of birth also. And it was one day before the surgery. And that day, the nurse came with a big, cake, asking her to, cut the cake and wishing her birthday. When the doctor came in, it was a delight. I said, what is this happening? So I think people are now, thinking on those lines. How can we make a visit to the hospital a delight for the patient? So some of the essential, elements for patient satisfaction, if you can integrate these in your services, I think automatically the patient satisfaction will go up. One is communication with nurses. So you really need to focus on making sure that your nurses are more communicative with the patients. Trust me, in Western countries, the nurses are trained to be the advocate for the patient. They actually represent the patient, and they talk on behalf of the patient, and patient safety is their primary concern. So I think on the same lines, we need to make sure that our nurses not only fulfill the requirement of what the doctor has instructed, but they communicate on their own. So in one of the hospitals, no, it was not the hospital, the Apollo Diabetic Clinic. So I met one of the doctor who who is working with the Apollo Diabetic Clinic, and he told me that he has trained his nurses to answer almost all the questions that the patient would have to ask from the doctor. But they may hesitate, or maybe because of the time shortage, they are not able to address those questions. But the nurses would make sure that first they talk to the patient, answer all their queries, and if there is anything that they are not able to address, they will put it in the remarks column that the patient wants to know about it and have not been able to answer, and they want the doctor to answer. Then the patient will visit the doctor. Then once again, the nurse would finally close the case by answering the rest of the doubt. So making our nurses communicate, so that requires training, that requires skill building, that requires empowering, that requires hierarchy also that we need to maintain. Unfortunately, I see in a lot of hospitals we are not employing qualified nurses. I happened to visit one of the hospitals for training. It was in northern India. So I thought I'll just have an introduction with all of them before I do a training for them. So I asked one of them, I said, who are you? Ma'am, I am so-and-so, I'm OT technician. I said, who are you? There were around 40, 50 of them. Who are you? He said, I'm so-and-so, I'm OT technician. I'm so-and-so. I mean, 60, 70% of them were OT technician. I was shocked. It was a small hospital. I said, all of you are OT technician, what is this? And then I asked, who's the nursing in charge? So there was one lady, they said she is the nursing in charge. I asked her qualification, she was ANM. Such a huge hospital. And these people who were not OT in charge, sorry, OT technician. Did I say right? OT technician? Yeah, OT technician.
Yes.
Then I asked them, where are you posted? One person said, I'm in lab. The other person said, I'm in OT. The other third person said, I'm in ICU. Fourth person said, I'm in labor room. I said, everybody in like every area, all OT technician in every area, then where are nurses? So what that hospital was doing, they were getting people, from the neighboring area, from the rural area. They were giving them OT technician training. So they will get more hands to work on, and they were being used as nurses. That's not going to work. So we really need to have nurses who are qualified, well-trained. Then communication with doctors is another area with what patients look for. So we really need to, train our residents, at least if you have challenge in training your consultants. Residents can be, made aware of how do you go about interacting more, in a more cordial manner with your patient. Then, of course, communication about medicines, they want to understand. So pharmacists can be explained, nurses can be explained, how do you go about communicating about the medicine so that there is no mishap on that front. Responsiveness of the hospital. So that means everybody, right from the gatekeeper to receptionist, to lab, to radiology, everybody is responsible to give a responsible interaction to the patient. Pain management, another important area. When patients come to us complaining that they have pain, we have to take their pain seriously. We need to assess their pain, get an idea. And I mean, when my daughter was admitted here, I think I shared with all of you that she was due in March, but incidentally she developed gallstone and she had to be admitted earlier. So almost a month in advance she was admitted, and she had severe pain. So every time the nurse came in, she would ask, can you rate your pain from 1 to 10? And then my daughter would say, it's 8 out of 10. She would write on the board. After 2 hours, again, when the nurse would come, she would check with her. Now, what do you say out of, from 1 to 10, what is the intensity? So asking the patient what is the intensity of pain, and then manage it accordingly. Then, of course, cleanliness and quietness of the hospital environment. I think we are attending to it in great detail. But again, I'm not sure of the infection control, how exactly they are going about. Then discharge instructions, another important communication which we make with the patient, but we need to do it more carefully so that there is no miscommunication on that. And then overall treating of the hospital. If we can look after all this, I'm sure patient satisfaction will definitely go up. So at this point, I want to quickly introduce you to a concept of design thinking. How many of you have heard of design thinking? I just stopped the...
I have, in fact, we usually used to have a conclave every year of senior leaders. So I had done this project. I had presented on design thinking in a hospital at that time,
Wow.
about 2-3 years back. So I at that
Did you
time
take it
researched a
forward?
lot on
Did
that.
you take it forward?
No, because then we came back, then there was a change in the leadership, and then COVID came and everything got haywire, but we've picked it up again. And now we are putting it a little bit, we are taking it up again.
Wonderful. Thank you. Thank you. I'm glad that you have tried your hands on it. Anybody else?
Yeah.
Have you heard of design thinking? Because it's a new concept, especially for healthcare. Have you heard of design thinking? Dr. Arjun,
Okay.
Dr. Kunal?
Because I teach in engineering college,
Yes.
because I teach in engineering college, it is one of the subjects that's there. So I am familiar with it.
So how do you use this in engineering college, if I may ask you?
Yeah, here it is, though I'm not the one who teaches it, but because it is part of the subject, the students are made to think in a way that, they are able to come up with certain creative ways of looking at problem and then coming up with solutions. So that's how it is. I do not have much of an idea, but then yes, I have heard about it.
Wonderful. So Chandana, have you heard of this concept, design thinking?
No, ma'am, I'm not that much clear to comment
That's
on
okay.
that.
That's all right. I know it's a new concept. So many of you may not have even heard of this. Dr. Arjun, have you heard of this?
Yeah, no, ma'am. I'm also not.
I completely understand because this is something very new. Dr. Rakshita knows about it. So Dr. Rakshita, would you like to share your thoughts? What do we mean by design thinking? If you would like to tell. I know you have done it. We have done it together. So you have an idea about design thinking. So how do we employ design thinking to healthcare? Oh, there's too much noise at your end. That's okay. So design thinking is a concept where you look at a situation or a problem on which, see, normally we have a tendency to quick fix things. For example, we are short of bathrooms, so let's have another washroom. Or there's no light coming from this side, so have a light here. That may work. That may work because when we are resolving small things, it helps. But design thinking is a very, elaborate tools that help you to align your services as per the requirement of your clients. So if I may quickly share this screen with you and further talk about what exactly we mean by design thinking. So design thinking is something where you align your services as per the requirement of your client. For example, if you look at things like Amazon, Uber, WeFast, Oyo, Zomato, and IHC, they are aligning their services to meet the need of the client in a manner that it's a delight to avail their services. For example, if you are looking for something on Amazon, you get almost everything. If you want quick service, you have a facility for within 24 hours. Even sometimes in 4 hours, they are able to provide. Similarly, if I talk about Uber, Uber has changed the way we travel. They have looked into everything. They have looked into the cost, they have looked into the distance, they have looked into the shortest time, then the cleanliness, everything. Similarly, lot of online services like WeFast, Oyo, Zomato, food services, all of them are actually using design thinking. So you must be wondering, what is design thinking? So design thinking is when you don't try to quick fix the situation, but you rather try to first of all identify what is the problem. So I took you to your OPD in the beginning of this session. If you take that as an example, I took you to various important areas which your patient will most likely visit if they happen to come to your hospital for OPD consultation. I made you move with that. Now, if you have genuinely gone to each department and have seen that department personally without being biased in favor or against it, you will be able to see where all we have challenges in giving a delight service to your patient. It could be lab, it could be radiology, it could be pharmacy, it could be waiting area, it could be reception, it could be the parking area. So to do that, I made you do empathy building. where I made you move like a patient to different areas. So if you would do it genuinely, you will visit every department very objectively. You will be able to see what we are giving and what do my patients expect. How can I make it a delight for them? How can I make it better for them? And then as a group, as a team, you will sit together and we'll try to see what ideas can we generate. Because when you will do brainstorming, when you will ask your team to give you answers, what all can be made to reduce this chaos or improve the waiting time or turnaround time, you will get a lot of beautiful ideas. And once you will try to evaluate each idea in a manner where you will try to look at the plus and the minus of each idea, and then the advantages and disadvantages and the utility of that idea, that means you will actually be evaluating each idea. You will come up with a solution, prepare a prototype. That means you're not applying it as it is, but you will actually be developing a small pilot study kind of a thing. You will implement it to a shorter or smaller area. For example, if you have decided to reduce waiting time in the hospital, so maybe you would like to first work on one area, maybe radiology or pharmacy or OPD or wherever you want to go. And then you will do a testing where you think that you will apply that whatever new mechanism you have kind of collectively decided. If that works, then you will use this as a solution to generalize or apply it. So design thinking is a wonderful concept to understand your patient's expectation and also to ensure how do you go about fulfilling it. It's a very beautiful concept. Lot of even healthcare areas are now using. For example, GE, Siemens, Philips. If you see there are now CTs and MRIs for pediatric clientele, you will see they have changed the way how the whole thing looks. Why do you think they have made it more colorful? Not just to beautify the area, but because they are able to see the apprehension and anxiety that the parents and the child feels in case if they have to go for this procedure. So just to allay their anxiety, just to make them feel comfortable, just to distract the child, they have gone, ideating on, having a colorful, bright, MI room or CT. I visited this hospital, Chacha Nehru Hospital, Bal Chikitsalaya, Chacha Nehru Bal Chikitsalaya. It's in Delhi, in East Delhi. It's a government hospital. So I went to one of the departments and where they had actually, made changes in terms of the color of the interior wall and then having some PlayStation around because that hospital caters to pediatric clients. So just to make children comfortable, just to make parents comfortable, they have changed the interior of the hospital. So that's how you can actually use design thinking to see how you can cater to your patients or their families' needs. So this is one of the OPD waiting area. So to many of us, it will look like a 5-star hotel. And if you have a clientele who comes from that background, so you need to have services where they feel that yes, this is something that's really required. Again, this is a OPD and waiting area of Apollo Cradle in one of the cities. See how beautifully they have designed it. How beautifully they have designed it. So this is not just the beautification part I'm trying to talk about. It is how can you cut down on their waiting time? How can you reduce their visits? How can you make their visit a delight? How can you serve them so promptly that they think of you and nothing else? So that's the whole idea of applying design thinking in understanding your patients and meeting their needs. So I think it's time we need to understand our patients' expectations and meet them midway. So one exercise that I will ask you to work on, that is try applying the concept of design thinking to the visit that you did to your hospital immediately. Try applying this.
Can I say something?
Please
Yeah.
go ahead. Yeah.
When I was researching on that design thinking, there was this hospital somewhere in the US. They tried to resolve medication errors with the use of design thinking.
Wow.
So what they did was, besides the medicine preparation table, they had put they had marked it like with a ribbon.
Yeah.
And once, that means do not disturb kind of a thing when the nurse is mixing the medication.
Oh.
So once she crosses that line and goes inside,
Yeah.
means it's a do not disturb area for anybody walking into that room. So the nurse is not distracted and there were less medication errors due to that.
Wow. So
Yeah, it was really nice.
wonderful. So actually, we have to be very creative now in finding solutions. And, I really believe in having, working on solutions because, I read a study where it said, it's a study by Harvard that says every problem has minimum 4 solutions, minimum, not maximum, minimum 4 solutions. And every solution should be tried at least 4 times before you give up. So that means there are 16 opportunities to solve a problem. And now it's time that we need to really go out of box, thinking about the possible solutions that you can provide to your patient. And people are innovating, people are doing. See, earlier, we never had this concept of somebody coming and collecting blood sample from home. Now we have people coming home and collecting. Then we never had this concept of, getting the reports at home. Now you get it online. You don't even have to go anywhere. It's available online. Physical copy will come later, but at least you will have a digital copy and you can share with your doctor and you can have an online consultation. So imagine at what a fast pace we are moving. And we just need to, critically and creatively think, how can we make things better from patient's perspective? And that's what I think is the requirement today, that we need to never start with the idea it can't. Start with the idea it can. Maybe I don't know the answer, but I need to find out. But something like this, I don't have an answer, is absolutely no. That's how we really need to now approach dealing with the situation. So I would say try applying this concept, or maybe visit any of the area where you are having more complaints, where there is more dissatisfaction, where patients are not happy, staff is not happy, you are not happy. Visit that area quietly as a just observer. Go through different, departments in the same area. Make a note of it. Look at the reasons of why you're getting more complaints or more aggressive reactions, or what is the issue. And then, as a team, brainstorm on finding how can we resolve this. I went to one of the labs for assessment, and the A4 size paper that was pasted at least 10 places in the blood collection center. The message was, your report will be available next week in the OPD from where you have come. And please don't ask any question. My immediate question was, suppose if the patient condition is not fine, for example, the patient has fever or has UTI or has a health condition where the patient requires the report as early as possible so that his treatment can be, changed or modified or corrected. Where will that patient go? They were clueless. So you can imagine the way we are catering, the way we are designing our services. Look at it. If you were the patient, what would have you expected? Or what hurdles did you have reaching to the OPD or meeting your doctor or going to radiology, pharmacy, or lab? These are the basic services your OPD people will visit, patient will visit. And you can start improving. So it's a very interesting topic, and I would really recommend that. Though this topic is supposed to be covered as a master trainer program topic that you need to be talking to your audience, but since I see most of you are in administration and you require this skill, so you can use this to help your management improve services using design thinking as a tool. Any questions about what we have discussed? Yes, Dr. Kano.
Is quality function deployment same as design thinking?
Quality
Function deployment, house of quality.
Honestly, I don't know about it. If anybody else knows, I would request them to share their thoughts. Honestly, I have no idea. I've not even heard of that. Dr. Savita, do you have any idea about it? Have you heard of this?
Could you please repeat that?
Quality function deployment. Quality function deployment. Yeah. It is also called house of quality.
No, this is it is actually more to do with your quality control, QC. So it's more about not about design thinking. Design thinking is more about facilitating or easing the way we function, because of which we come up with new plans and new ideas. Whereas quality, where you're looking, it is more to do with establishing norms to meet standardizations. So that is where you have those ISO things.
Okay.
Usually hospitals are also having ISO certifications. So those kind of things, yeah.
Okay.
So honestly, I have no idea, so I can't comment on it. Yeah. But if anybody knows, you're free to share your thoughts. In case if Dr. Rakshita knows about it, if you have heard of it. Okay. So with this, we come to the end of this session on understanding patient expectation. Any questions about what we have discussed?
Ma'am, I have one thing. Like now, when you go to the parking of a hospital, valet parking will be a delighter.
Definitely. Again, if it's a 7-star hospital or a 5-star hospital, probably you will have a clientele who would expect this to be part of the service. So for them, it could be a satisfier.
Okay.
But if it's a middle class person visiting your hospital, then it will be a delight.
Okay. Depends on various.
And for me, it came as a shock when I went to Hayat Regency, and they took my car for valet parking. I went in to meet somebody. When I came out and I asked for the key, he said, "Ma'am, 50 rupees." I said, "For what?" He said, "For valet parking." I said, "You should have told me that you're going to charge me for my parking. I could have gone and parked myself." So we all have varied experience to share. But yes, if it's a huge hospital, then probably the kind of clientele you will have, they will expect valet parking to be part of the service. Yeah. Good question. Any other question? Any thoughts about what we have discussed? Does it change your opinion towards patients' expectations? Understanding?
Yes.
I think we need to be more empathic with the patient and their family when we are designing our services. It should be considering how we can make it more comfortable, convenient, smooth, least waiting time, reducing number of visits, even cost cutting, if you can do that. Because financial burden also, bothers. It bothers.
Actually, cost can be a very important expectation of the patient, that it should be economical or affordable. That will be a very major important expectation.
Okay, I agree completely. So if there are no more questions, I'll quickly share, first of all, the feedback form for this session. And then we will have presentation by Professor Savita. And incidentally, I didn't realize none of you opted for your presentation for today. Only Professor Savita has agreed to do her presentation. That also because next week she's traveling, so she will not be able to make the presentation. But nobody, opted. So first thing now, I want all of you to immediately open that document simultaneously and write your name and the session you will be doing, please. And meanwhile, I'll share the feedback form with all of you. So Dr. Rakshita, it's not about March or April. I think we'll have to tell which session number you will be doing. We are having once a week program, so it's already 15th today. So we'll be having how many more sessions this month? 2 sessions are left. This session 5. So 6 and 7 will be in March. So I'm opening that document and I want to see if everybody has really, replied. I'm really surprised. Nobody actually opted for session 5. And please also see if there are others who have already opted for the same session. So, Preetaji, if you could change your option.
Ma'am, I can go for topic number 5 or 6, even though 6 is more interesting to me.
Okay, so you had written for interesting ice-breaking.
No, I haven't written. You just mentioned that nobody has gone for topic number 5. So I just
No, not topic number 5. No. I'm not asking for session 5 because I had asked.
Session 5. Okay,
Session
ma'am.
5 for today's session. Yeah. So you have written interesting ice-breaking activity. If you think you would like to go for it, only thing is session number 11 is not there. We have only 10 sessions. So you need to change your session number. So should I change it for you? So even for session 7, nobody has agreed. 8, for 8, Dr. Arjun has written session 8. That's okay. Handling difficult audience. Session 9 also 2 people have opted. Okay, session 8, 2 people have agreed. Handling difficult audience done by Arjun, Dr. Arjun, and introducing a topic in an interesting way, Dr. Kunal Thakur. So if you could write your, Dr. Preeta, do you want me to change your session number? Which one do you want to go for? Shall I write 6 for you?
Ma'am, I'm not able to write it there. I think I have some internet
I'll
issue.
write it for you. You tell me, shall I write 6 for you? Next session?
Yes, ma'am. 6. Yes.
Okay.
Not 6 session, ma'am. Topic number 6.
And not this one, interesting ice-breaking activity that you have written?
Using creative visualization to enhance experiential learning.
Okay. So I'm writing your name, but I want you to tell me when will you do it?
Okay, ma'am. Let me check. Session 8 is booked. Okay.
And what about next session? Nobody has yet given their consent.
Ma'am, session 7.
6 and 7 both are vacant.
Ma'am, session 7.
Okay, I'll write for you.
That's okay.
Yeah, I'll write session 7 for you. What about others, Chandana? Tanu ma'am, have you given your consent?
Yeah,
Session 9.
Session
Okay.
9.
Session 9, that's okay. Namrita, which one have you picked up? Session 10. Okay. So we have 2 people on session 8, and then Dr. Tanu on session 9. Also Amreen Sheikh on session 9. Anuradha again 10. 10 we have how many people? Okay, 2 people. So for session 6, I have not got any name. 6 and 7. Yeah, for 7, Preeta ji has agreed. Dr. Rakshita, are you there? Who all are there? Dr. Rakshita, are you there? Yeah. So if you could write the topic that you wish to take and when do you want to take it, I could, or tell me, I can enter it for you. So you're filling the form. Okay, that's fine. Yeah. So I think we'll have only one presentation today by Dr. Savita. Dr. Savita, are you ready?
Yes, I am. May I be allowed to share my presentation?
Yeah,
please?
give me 1 second. I'll enable that. And also, I hope all of you have given your feedback. Please finish your feedback for this session, and then we'll go move with the presentation.
And presentation should be for 15 minutes, right?
15 minutes, because we will be having 2 presentations every time. So
around 10 to 15 slides or something like that.
Just 4-5 slides. And before the presentation, I would like to speak to the presenter, because we should be very clear about what we are going to present.
So we should share our presentation.
Yeah. So you need to share the sample of what you are talking about, then talk about advantages, disadvantages, do's and don'ts, and application. See the form that I have given you. I'll just share the screen with you. Give me a second to show you what I have written in the this thing. This is okay. So I'm sharing this with you. If you look at the top, very clearly I've written, choose one topic of your choice, enter in the box and mention this session you will present in. On any given day, there will be only 2 presentations, 15 minutes each. Time allotted is 15 minutes, please remember. In the format of presentation, please give a demo of the pedagogy you are talking. Start with the demo. Start with what you are going to talk. For example, if you want to talk about storytelling, so you will have to narrate a story to give us a sample. And then discuss about the pedagogy by telling what was the name of the pedagogy, advantages and disadvantages of the pedagogy, do's and don'ts, where all it can be used. That means application part. So please don't prepare more than 4 to 5 slides about the pedagogy. And then please discuss your activity and PPT with me before the presentation, so that we are on the very clear what exactly we are going to present. And in case if you have any question, please message me. I'll be there to help you. I hope that helps. So somebody is okay. So can we have the presentation by Dr. Savita?
Yes, please. So may I share?
Sure, please. I have already enabled you your screen sharing. Yeah.
I have to actually.
Some
Just give
challenge?
me a moment.
Sure.
Yeah. I'm doing it from my mobile because I'm unable to access my the sound is not working properly. So because of which I'm just.
But I'm not sure if you will be able to share your screen. Try.
I will be.
Oh, I have never done it, so I have no idea if you can share your screen from phone and how it looks. I have no idea.
I'll do it. I'll do it.
Mhm.
I'm not able to. Are you able to see my slide?
No.
Oh God. I have shared it with you. Then is it possible for you to share my PPT, madam?
Give
Or
me a
I'll
second.
reshare my PPT.
Yeah.
I'll reshare my PPT because I've added one slide.
If you can email me, that will be better because on WhatsApp it may not be.
Okay, I'll do that.
Yeah. Even if you WhatsApp, then I can email myself if that's the thing. Whatever is easy for you, just tell me.
I'll do that. I have done it.
You have
I
emailed me?
WhatsApped it. No, I WhatsApped it.
WhatsApp it. Okay, let me. Give me a second to get it.
Yes, yes.
Okay, there we are.
Okay.
Yeah.
Yes. Can we have just one screen, please?
Actually,
We are
it's a
having two
PDF, I think.
slides being shown.
It's a PDF. So if I try opening with another missing tool, then it might take longer. So is it
Okay, never mind, never mind. Yeah. I'll do it.
I can try it, but it might not work.
No, not a problem, not a problem. Yeah. Good evening.
1 second, let me try. Shall I try?
Yeah. No
Okay,
problem.
let me try
Please
if it works.
I didn't want to take too much time.
Yeah, I know. Even I was thinking on the same lines.
Yes, that's great. Thank you.
Yeah. Please go ahead. Yeah.
Thank you very much, ma'am. Yeah. Good evening, everybody. My topic, which I have chosen, is circuitous questioning as a method of facilitating responses. So here it is. I have a picture in front of you. So I would want you all to just look at this and tell me what you think about this. Is the picture visible?
Yeah, it's very clearly visible. Yeah.
Okay, yeah.
I think there are people on both the sides of the fence.
Yes, please.
Evacuation.
I didn't get it. I could hear the word Afghanistan.
Afghanistan, and the child is being, it's probably from that incidence where children were sent, thrown across the barbed wires to the airport so that they could be carried out of Afghanistan.
Crossing the border.
Okay. Yeah. Okay, crossing the border. Anything else? Anybody else would want to share?
It looks like the child is being moved from one border to another, from one place to another.
Okay.
It was a critical movement. Like everybody is trying to
Okay.
save the child.
So,
Yes.
okay. So, what else can you? What do you think the situation is in which this particular act is being performed?
Trying to save the child or trying to save the future of the child.
Okay.
I think that's what it looks like, that they are, I mean, that's the only choice they have, to save the child.
What situation do you think the people are in?
That they are left with no option than to do this.
Mm-hmm.
Okay, I will
Desperate.
rephrase the question saying that what circumstances could probably lead to such a act?
Fear of
What
life.
circumstances could probably lead to such an act?
Mm-hmm.
Okay. And why do you think they are fearing their lives?
So maybe it's a war situation or terrorism or something very extreme.
Okay. Okay. So, yes, thank you very much. So what we have just done is questioning here. So when we talk of questioning, could we move on to the next slide, please?
Sure.
Yeah, thank you very much. So this is the picture of Socrates, and I'm sure we have all heard of him. So Socrates was the one who actually developed this method of uh, coming to some kind of answers. So it's a quest for answers. It's a quest for understanding where it is initiated it's a self-initiation. So all it needs is questions being put by the other person, and through answers, you are trying to arrive at an answer. So that's where, the whole questioning process is all about. Ma'am, could you please take it? I'm sorry, I'm putting you through this.
No, not at all. It's not.
So this was the topic that was there, which I chose, Socrates questioning as a way of facilitation. So when we talk of the word facilitation here, it is all about letting the other person do, encouraging the other person to go ahead or say something or do something. So the active participant is the doer or the sayer, or here in a clinical situation, it could be the patient. So when you are looking at trying to get an answer from the other person, you are putting the right kind of questions, or questions which will lead towards the answer. So that's how it goes about. The next slide, please. So no, I think there's one more slide there, which talks of the definition. I think yeah. So when you look at what is actually Socrates questioning, it is a way of questioning in a very disciplined manner and a thoughtful. So here you have a very organized way of putting questions in a very systematic manner, and you are having a dialogue between two or more people here. So it is like nobody is the master and nobody is the student, or no, there is nothing called as a hierarchy here that somebody is superior and somebody is inferior. It is more out of a general discussion, and one person is putting questions, or you could also say leading questions, which will make the other person look out for answers, and it is more of a self-initiated response. So the whole idea here is, if I have to put the right kind of questions, and if I want to get the replies from you, the quality of questions I put to you should be in such a way that I can elicit that information from you. And all the while, it would be like you are doing it on your own. It is not I am telling you. So it is more of an initiation from your end. The next slide, please. So when you look into Socrates questions, the type of questions that you ask are different types. These are the 6 major types of questions that are there. So very often you have clarification. So when you talk of clarification, you want more information about it. So you are clarifying doubts. So you want more details about it. So you put questions like, why did you say that? Or, what does that mean? So here it is not in a very, where you're having an anger in your voice, or what does that mean? But it is more of seeking more information so that there is less miscommunication. Similarly, probing assumptions here leads to, this usually happens when we make certain remarks about anybody's dress. Like, I think you could make a very casual remark just looking at a person and say that, I think that person is, uh, like, doesn't belong to this country or doesn't belong to this place. So that is when you are trying to, what led to that kind of an assumption. So you are putting questions like, how can you validate it, or what made you think that that person doesn't belong to this country or this city? So you are putting those questions. It could also be like when you are seeking some kind of a reason and evidence. So you have like, what do you think the cases causes are, and why do you think this has happened? So usually, like when you're going through your exams, you have people putting those viva questions. So here you're trying to find out the reason and seek proof to why you think something has happened. It could be with reference to patient treatment or diagnosis. Similarly, it is also about perspective, probing perspectives here. So, like, instead of being judgmental about a situation, you can also, or, like feeling hurt when somebody has said something. Okay, I think this person meant, like when you say that, when this person looked at me in that way, I think that person is not happy with me or is angry with me. So here you are trying to probe the perspective and say that, why do you think so? Well, that person was very curt in the way he spoke to me. So I think he or she doesn't like me. Then you are probing the perspective. Like, can there be another way of looking at it? could that person be very stressed, or could that person be thinking of something else, because of which he or she could have responded to you in such a way. So this is where you're putting questions to probe perspective. And then you also have something called as implications here. So you are trying to look at, okay, if you take this kind of a decision, what do you think could happen? So whether it is implication with reference to what you say or what you do, if I take this decision and go ahead with this kind of a treatment, what could be the possible results? So you are kind of looking into that aspect. Sometimes you're also questioning about questions like, when somebody asks you a question, like usually it is said, especially nowadays when interviews are held, and if the interviewer asks you, like, are you married? Then you can also ask, why is this question relevant? What has it got to do with my applying for this position? So this is where, you are questioning there. But then in a situation where you're looking at trying to elicit information, if I have put a question to you, you can also ask, why have you put this question? What made you think about this? What is it that made you think of asking me this? So you're trying to probe deeper and deeper into it. So this is how you have different types of questions that are there. So when you are getting into this form of questioning, it's very important for us to spend a lot of time to think of the situation that we are going to be in, and put a list of questions that we could probably ask in a situation, so that the other person is able to understand and give responses. It makes our questions will make the other person think and give responses, and in the process of thinking and giving responses, there is a lot of clarity to that individual. Like if I were somebody was asking me questions, I wouldn't respond just like that. I would think and give response, and then for the same response, one more question is given, I would keep on thinking. So it is more of a way of introspection, I would use the word. So could we go to the next slide, please?
Sure.
Yeah, so you have just some advantages as well as disadvantages of using Socrates' way of questioning. This cannot be used in all situations. One of the advantages here is, it develops your listening skills. So you need to be into active listening. And when we talk of active listening here, it means like you are looking at the person and not just hearing the words or listening to the words, but you're also looking at that individual, the facial expression, the intonation, the paralinguistic features, the gestures, and all of that goes into it. So you are paying 100% attention to what that person is saying and trying to understand what is being said from that individual's perspective. So that a lot of active listening goes into it. It is also promoting your critical thinking, because when somebody is putting a question to you, you are thinking. You are, so you are not just, there's a lot of thought process that is activated there, and a lot of reasoning is involved there. So that is where your critical thinking skills are kind of developed. Then you are also looking at, learning how to be challenged and what to do when challenged. So very often here, when somebody is putting questions to you, it can also be like, they are questioning you, so it is like a challenge to you. So what do you do when someone questions you? How do you answer them? And how do you think what would be an appropriate response to it? So that is where, and the more number of questions somebody is putting, the more fine-tuned your thinking becomes. Then that is where you have the next point that comes, you try to examine issues at a micro level. So you go more deeper and deeper into the thing, and you're doing it all by yourself. You're not getting ready-made answers there. So that actually helps you to do that, some kind of a deep thinking, get more intensive about whatever that you wish to talk. It is also, normally it helps you to review, restate, emphasize, or even summarize what is important. Very often we look into this aspect where, when we have a problem, many times we like to, we find it helpful when we talk to others, not because the other person will give us a solution, but probably when we are talking to others, the other person would put a couple of questions, and when we are trying to answer those questions, a lot of things fall in place, and there's a lot of clarity to the way we think. And during the course of our communication, or that we are having, we would probably end up finding the solution to the problem by ourselves. So that is one way of, those are the advantages. On the other hand, when you look at the disadvantages here, it's very important for people to participate in Socratic questioning, because when somebody is putting a question and the others are not responding, the whole purpose is defeated. So it's important that participation is necessary. So the other thing is, the other people may not be comfortable talking in public, so that can become a disadvantage, like when they do not know the language, or they do not have the confidence. So that is where it is. And especially when you have Socratic questioning in a group, and groups are generally small, but sometimes when you have large numbers also, you can divide those large numbers into smaller groups. And if the person is individual is looking at only one person and talking, then the others kind of feel neglected and they lose interest in the discussion, or in the whole process. So the especially when you look at the areas where Socratic thinking would help, especially like we would look at it, the like philosophy or other kind of topics. So sometimes there may not be one right answer. So when there is no one right answer, people may not be very happy about it. So that is another disadvantage. So when there are multiple kind of different responses to it, then it becomes difficult, because the whole process of Socratic questioning is one question leading to the other, and then another question and another question. So if you have multiple answers, then you will find different multiple pathways, which can become complicated. So that is one of the other disadvantages. So could I have the next slide, please? So usually when you are into a Socratic questioning, if you want to conduct it as a way of trying to make the other person come up with responses, it's better to keep your questions simple. So ask single questions. So do not have, um, as we can say, multiple questions in one question. And it's very important that you are precise, clear, and concise the way you frame your questions. So here it is important that your language that you use, they are very easy to understand. And it is important for participants to participate in the dialogue. It's okay if you say that I don't know the answer to it, then probably another kind of a question could come up, which will lend a little clarity and evoke a certain kind of response. And the other important thing that you need to do is, your question should be framed in such a way that the answers are much more explicit than just a mere yes or no. So yes or no type of questions, like normally we look at into research, they are closed-ended questions. So we need to have open-ended questions where they have opportunity to describe or explain and be a little more, explicit. On the other hand, the do's are where, yes, when you say that you need to be clear and concise, the don't would be avoid vague or ambiguous. You don't need to look at your audience or look at the person, the other person. You need to understand what is their level of awareness, knowledge, language ability, and then accordingly you need to put your questions to them. Otherwise, if you are speaking at a certain level and the other person is at some other level, then there would be a mismatch, and the purpose is defeated. They wouldn't understand what you're saying, and they wouldn't be in a position to reply to you. So if you have put a question and the other person is unable to answer, we shouldn't be giving the response. Instead, we could rephrase the question in a more convenient way for the other individual to give you a proper response. And even when you're giving response, it would help if you're being, to the point instead of giving elaborate responses. The most important thing in Socrates' questioning is to not be the sage on a stage. This is especially when this method is used in the education system. So when here you are, the sage on the stage is the term that is used in the field of education, where the professor is, I know everything. So that know all position, no. Here the professor actually has to act dumb and the kind of questions, it is like, I don't know anything about it. So I'm putting you questions after questions to get more information. And in the process, you are simplifying the whole thing and able to answer me better. So that is where it is. And lastly, it helps to not use jargons, because again, you wish to make your language easy for the other individual to understand. I think it's the next last slide that I have, ma'am. Yes. So where can we use Socratic questioning? So very often, Socratic questioning is used in teaching and in counseling. So when you are conducting counseling sessions, somebody is coming to you with a problem. So instead of being a sage on the stage, you're actually putting questions. Okay, so I'm feeling very depressed. So why do you think so? And if there is some response, you just use that response as a base to frame further questions. So that is where you're, leading one question to the other. It is also very often used by psychologists and even in psychotherapy, where your deeply seated fears or your values or beliefs. Sometimes we just believe certain things, and if you want to understand them, this kind of questioning will help you unravel why you are thinking about something the way you do. And as mentioned, it is used in cognitive behavior therapy to encourage behavior modification. So here it is not telling the person what you need to do, but then actually questioning why they think they need to be the way they are. So it involves a lot of, making the person think why they are doing or saying what they do. So this is where it is. It's more used in subjects like humanities, and the pure sciences, it's not kind of used. I think that was the last slide, ma'am.
Yeah.
Was it so? Yeah. So this is it. Am I supposed to be doing anything else?
No, I think that's okay. I think you gave a good overview of what Socratic questioning is. If we could also tell about how will they use this in the training program, because the whole idea of introducing them to Socratic questioning is to use this as a pedagogy in the training program, because ultimately the idea is to have more options in their kitty. So like for example, we did case study today, and
Yeah.
in the end we had Socratic questioning around that. So it's not just about the philosophical issues, but even practical problems over which people react differently or behave differently, and you can't point out to their behavior. So that's a nice way of kind of helping them sit and realize, oh, this is not the way, or this is not the only way. So rather than saying you are wrong, if you tell them what are the other options and help them explore the other options, they'll come up with more ideas. So that's where we can use Socratic.
Yes, like in a
learners. Yeah.
Yes, in a clinical situation, suppose there is an incident, any incident that has happened and has occurred, and you want people to understand why it has happened. So, so instead of blaming or saying that, okay, this shouldn't have been done, trying to put it across, why do you think such a thing has happened? Or how do you think your responses should have been? How do you think things could have been different? So you're trying to make them look at it from different perspectives, different angles, so that they understand where they have instead of saying gone wrong, I would say that probably not done the right thing. It will kind of bring that kind of an enlightenment, and maybe they'll look at it in another way when they come across a similar situation.
Very true. Like Socrates says that I can't change people, but I can make them think. And that's the only way to help people learn new things. If they can think creatively, they can change their ways.
Yeah.
Thank you so much. I think Professor Savita, any questions about what Professor Savita has presented?
I think only the question which you asked, that how one use it in clinical situations. So that's already been answered.
So does my answer help you in understanding how we can especially it's a very useful technique where you cannot say something directly.
Yes.
And when you know clearly that this is the fault of team or one person or the system failure, so you want to take them closer to the solution, and you don't want to suggest the solution. So these type of questioning help you to take the team towards the solution or the way of changing their behavior or services or whatever. And I mean, you actually have to design your questions very sensitively. They should be non-pointed, but they should be very clear where you are taking them. So you have to be very careful while designing your question. They should not sound judgmental or, yeah, you were saying something.
When you are designing
Blaming
your question, so when you're designing your question, you might start by designing your questions, but as the answers progress, you might have to
responses
improvise.
come.
As the responses come, you might have to improvise on the spot. Yes.
Yeah. So I will always say, when you
Yes,
want to
yes,
practice
yes.
this as a tool, as a technique, start using it with the type of audience where you don't expect to have question on the question.
Okay.
That's another
Because
risk,
that is one of the 6 types of questioning that was told.
Yeah.
Yes.
So don't ask questions that are pointed, that instead of actually answering them, they may start asking you, what is the relevance of asking this? So initially start practicing with the audience who would be ready to explore, would be open to the idea of, looking at things from your point of view, and you are navigating them by asking those questions. Basically, you're navigating them to the answer, but you want the answer to come from them. But once you will become master at it, then you can do it even with the senior most. Yeah. And there's another technique which we were taught in Dale Carnegie, and we were made to practice, and that was instead of answering the question, you ask a question as an answer. For example, you ask me, where do you live? So I will not tell you where do I live. Why do you want to know? So, and we were made to do this exercise for good 1 hour. So we were like 2 parties.
So you ask as like, do you live in Delhi? This is how you ask the question then.
But again, the question can be what has you to, what have this to do with you? What has this to do with you? Why do you want to know about my place of living? So that means you don't answer, but you ask a question to the question. That's usually when you are dealing with disruptive audience.
Elements, yes.
And there you can use this as a way to
when you're difficult people, yes, correct.
But then you have to be very careful
how
using this as a technique, because this can be very offending and can trigger resentment. So we have to be very careful when we are doing something like this. Any other question from all others who are not visible, but they are there? A lot of people have gone in silence. Dr. Arjun, are you there, or it is very late and you are tired and sleepy? I know it's...
Ma'am, because of my final issue, that's why I switched off the camera, because I had to walk.
Okay, no problem, no problem. So I think we'll close it here. It's quite late for all of you. And we'll have, but I have not received 2 names for the next presentation. I'm really surprised. Why are we hesitating in giving our names? So please have a look at the list of the topics and the names, and make sure that we have 2 presentations in the next session. So if there are no more questions, should we end it here?
Yes.
Thank you. Thank you, everyone. Good night.
I think, Dr. Savita, that was a very nice
much.
presentation. That was good.
Yeah, it was very thoughtful.
Thank you very much, Doctor.
Thank you.
Yeah,
it's a difficult topic.
Much.
What you picked up is a difficult topic, not very easy to explain also. But you being a teacher and a trainer, I think you could do justice to it.
Justice.
Thank you.
Thank you very much.
Thank you.
Thank you. Coming from you.
Thank you all.